Hello and welcome. I'm Autumn Lafretta, the Education Manager at the Foundation. Thank you for joining our Answers from the Experts Q&A. We are very excited to have you here. Before I introduce our panelists, I would like to go over some housekeeping. Q&A. Please add your questions to the Q&A tool in Zoom. We will be recording this and the video will be available on the Foundation's YouTube channel in a few days. Upon conclusion of the webinar, there will be a survey that pops up on your screen as you exit. We would appreciate you taking the time to complete the survey. We would like to thank our individual donors and our funding partners for making programs like this possible. Now, I would like to share some information on our speakers for today. Today, we have with us Dr. Mary Jo Lechowicz, who specializes in hematology oncology. She is a professor of medicine in the hematology division, vice chair for education in the Department of Hematology and Medical Oncology at Emory University. We also have Dr. Zachary Wolner, who is an assistant professor of dermatology and dermatopathology and a member of the Winship Cancer Institute at Emory University. Let's go ahead and get started. Welcome, Dr. Lechowicz and Dr. Wolner.
Thank you for having us.
So before we get started, I want to have one disclaimer. Dr. Lechowicz and Dr. Wolner are here to answer your questions based on their experience with patients that they have seen. So please do not consider any of their answers a second opinion. So with that, let's pull up our first question. Is there any other option besides going MOGA every 14 days for the rest of my life? Will this flaky rash ever go away?
I'll take the first question. It sounds like the person has gone past the initial month of mogamulizumab, which is weekly, and then every other week. The short answer is that the way that the drug was studied, that it continued on for patients continued to take it as long as their disease was in remission, every other week. Until there was possible progression of their disease. There are some people trying to look at other ways to do that, but that's all in investigational form at the moment. And that's also a conversation to have with your own primary oncologist.
Thank you. And for the other part, our goal is always to get this better with treatments. And how I always like to phrase this with my patients is that if you have psoriasis or eczema, it'll be a similar story. We often don't get this to ever go away, but we have lots of tools and tricks to kind of keep it at bay and have it have a minimal impact on your life.
Great, thank you both for those answers. Next question, I am Stage IIB. Smear showed leukemic picture with Sezary cells. Flow cytometry came back normal. Being considered for PUVA, methotrexate, and spot radiation. Benefits and side effects of each and how you would choose if this was your patient.
I will take at least the treatment side of this. Determining the risks and benefits of different treatments really depends upon a discussion between you and your provider and determining what would benefit you the most and what risks you're accepting to tolerate. Methotrexate itself is a medication we've had for a long time and used for many different diseases, including psoriasis, eczema, rheumatoid arthritis, psoriatic arthritis, and then in much higher doses, we use it to treat leukemias, lymphomas. But for this, we'd be treating this more in like kind of the inflammatory disorder range, which is around, you can anywhere from like 10 milligrams up to 30, sometimes even a little higher. And this can be taken for a relatively long time, very safely. It just does require some regular lab monitoring. As for spot radiation, this is often something that gets something better quickly and can really result in rapid improvement. But this doesn't last forever. So we often need to consider doing something else after doing this to kind of keep the disease at bay. The other option was Acitretin, is that right?
Methotrexate.
Oh, PUVA. Okay. And PUVA, I think, is another old therapy we've used a long time for psoriasis. You do have to take a pill, and I think the main side effect patients experience is nausea with taking the medication, which if we take it in lower doses, or you take it with food or ginger ale, that can help. The hardest part is logistics. If you're someone who's working or has kids or has a busy life, going to get phototherapy 3 times a week can be very challenging. And unfortunately, this is an old treatment that's kind of coming out of favor for a lot of other diseases. So it's often really hard to find a center that offers this. But if you happen to be lucky and live near an academic center, and it's not a hard commute for you, this would be a reasonable option.
And I think the other part in terms of the smear versus flow cytometry, which the next question has some themes to this as well. Unsure about the timing of when the flow cytometry was done compared to when the smear was done. And also unclear about, in anyone's local institution, sort of how they gate the flow cytometry and the sensitivities they're looking at. So it's hard to say in terms of kind of why there's some discordance there.
So that would be something good for them to discuss with their physician the next time they're in to get a little bit better information on that. Great, yes. Thank you. Have you had any experience with Sezary syndrome causing memory loss as it progresses?
So Sezary syndrome itself is not often known to cause memory loss. Having said that, I think as things progress, there's as all of you know, there's a lot of other things that go into this having Sezary syndrome, and many patients will come in with a flare where they're itching beyond the ability to be, their suffering to be minimized, and then their sleep deprivation and the like. There's also, as you all know, a number of the medications that we use for itching, and all of those things can make people sleepy and can have challenges. Patients often talk about word finding issues as the first challenge, but I think that it's a multifactorial thing in terms of, is it the treatment? Is it some of the side effects of the treatment? Is it some of the side effects of the disease? All of those things come into play.
Okay, thank you. How much does stress impact MF?
I'll take this one. I think that what the patients tell us is that stress does have impact on MF in terms of times of flares. In terms of how we can look at that scientifically, that's a lot harder to say in terms of kind of comparing one person to the next in terms of their levels of stress. But those that have had MF for some time know, and other sorts of cutaneous kind of lymphoproliferative disorders, particularly something like lymphomatoid papulosis or other sorts of things, notice when they have flares or something stressful happen, that they can correlate it quite specifically.
All right, thank you. Our next question: is a Buffy coat smear, Sezary preparation, better than flow cytometry in picking up tumor cells in the blood? I think this referenced the earlier question.
So I think that, again, that's going back to how I answered it earlier, that I think mostly what we try to rely on at this point is flow cytometry. If someone's looking at a smear and they see kind of irregular cells, obviously that's of some concern. In our staging itself, in terms of blood involvement, we have a number of different quantified areas in terms of B0, B1, and B2. And from the point of view of, it all depends on, at your own institution, what's available. I don't know of particular data looking at kind of the two of them head to head. I don't know. Do you, Zach?
No, I don't.
So I don't know that there's necessarily one over the other. Most of our guidelines have a little bit of both, because we want to ensure that not only in this country, but in other countries, if your resources are only the Buffy coat, then then able to be able to stage people appropriately.
All right, thank you. Do you have any experience with sunburn UV issues on the most affected skin areas?
I guess I'll take that one. I'm guessing this would be in reference to either skin affected areas that get ultraviolet radiation, or is it whether treatment related? I think usually we see cutaneous T-cell lymphoproliferative disorders as responsive to ultraviolet treatment, which is why we use narrowband ultraviolet B or PUVA. Are both great treatment options. And in patients who can't get access to these things and are low risk for getting other skin cancers like squamous cell and basal cell, some type of natural sunlight can be helpful. As for a sunburn, that's always a risk. If we're getting ultraviolet radiation, you can still get a sunburn in those areas. And that's still a risk with whether it be narrowband ultraviolet light phototherapy or PUVA, where we are still exposing you to ultraviolet radiation, and that does have a chance of causing a burn. I don't know if it makes it more likely. That I don't know.
All right. How often does someone with stage 1A progress to more advanced disease that may become life-threatening?
I can take that one. I think this depends on a lot of things. And with just stage 1A disease, it can be hard to know. But in general, data is just about 10% of patients progress. And what that means is that could just mean more skin involvement for a lot of people. So that just means instead of having one plaque or kind of patch on your arm, then your whole arm's involved, or you have some on your trunk as well. Then for a rarer or smaller group of patients, so this then means something else. So I would say stage 1A disease is a very, very good prognosis. It's something that you're going to be living with for most patients. But again, this is with the caveat that there's other data that we need here to kind of assess. And this is population data, and each individual is different.
We've had many clinicians say if you've seen one patient with cutaneous lymphoma, you've seen one patient with cutaneous lymphoma, because everybody is unique. So, all right, our next question. I was diagnosed with primary cutaneous anaplastic large cell lymphoma in 2018. I had one lesion, and again in 2020, same diagnosis, new lesion. What is the likelihood of a reoccurrence of the disease now that it is 3+ years since the last event? That's a probability one.
I don't know if we'll have a probability for you, unfortunately, but I'd say the more time, the better. It tends to be something that responds very well to treatment, and that we can manage well. So that's overall a good thing. If it does recur in an area again, there's lots of great treatment options, and it seems like you respond well. So that bodes well for your future. But again, limited information about what's going on in your specific case.
All right, thank you. So on this next one I read ahead, there are some things in the last sentence I have no idea how to pronounce, so I am not going to attempt to butcher it. There's always at least one word that I flubbed, so it's not going to be this one. So I was diagnosed with MF stage 1B in April 2022. It was well controlled with NBUVB, Acitretin. Nope, missed it. I continue to struggle with itchy scalp. Doctors say that this is dermatitis, not MF patches. I have gone through exhaustive patch testing, so contact derm is rolled out. So they mentioned some treatments that have not been helpful, and they're asking if you have any other suggestions, if you had a patient that has tried these treatments and it's not helping. It looks like it's mostly topical, so yep. Dr. Wolner, would that be one for you?
I'll take it. This is tough. One thing you could consider is biopsying the area, again, just to see if this is related to your Mycosis Fungoides or get additional information. A lot of times skin biopsies aren't, they don't, how do I put this? They're not going to give you a definitive answer. It's just an additional piece of the puzzle to help figure out what's going on. But there's still lots of things you can try. There's lots of pretty wide differential for an itchy rash on the scalp, including psoriasis, seborrheic dermatitis. It could just be what's called scalp dysesthesia, where you kind of have a pinched nerve leading to abnormal sensations and itchiness in the scalp. And then you get a rash due to scratching. So there's lots of potential things that could be going on there, and it's hard to say without the full clinical picture and history. But I would just continue working with your provider and try treatments as they're recommended and see if you can get something to help. It's tough because narrowband phototherapy, if this is mycosis fungoides, definitely doesn't work where you have hair, especially on your head. Whereas acitretin could potentially be helping for something like psoriasis and mycosis fungoides. So I think you could consider biopsy. You could consider additional treatment options, as you really haven't tried many prescriptions. It sounds like there's a bunch of potential other things you could do.
Thank you very much. That was a really good answer for all of that was in there. With CRISPR in the news regarding actual editing out of a disease from cells, is that a viable area of research for people with T-cell lymphomas?
It's going to be tough to say what anything that can kind of scissor or take out disease itself, how it's going to extrapolate into T-cell lymphomas itself. I think part of it in terms of you'd have to know some of the different targets and the like. And we still have a long way to go in terms of trying to figure out exactly how to do that. So great question, and lots of interesting technology there. And we are doing our best and continuing to work on it.
All right, thank you. I've been treated with UVB therapy with resolution of rash. Is it important to treat recurrent or new skin lesions that remain minimal? Does treatment impact long-term survival or have an effect on risk of transforming to a more severe stage? Excuse me.
Yeah, I think Stage 1A, like we said, is an excellent prognosis. We don't have evidence to suggest that what we do, especially early on, will change what will ultimately happen. So I would say there's even evidence to say if it does minimally impact your life and it's very minimal disease, watchful waiting is a reasonable approach. That to say, just because we don't know it now doesn't mean we won't learn it in the future. That maybe treating does change things, but I think if it's minimal and it responds to phototherapy and this isn't too much of an impact on your life and you feel better treating it, it's reasonable to do it. If the treatment is impacting your life more than the disease, then you can also always consider watchful waiting with very limited disease like Stage 1A.
All right. Our next one is, what new treatments can put CTCL in remission? And this one's a little bit of a loaded because it depends on what you determine as a new treatment.
Yeah, I think the way to answer that is that similar to the earlier question or conversation, is that we are doing our very best in terms of, working on new treatments, different sorts of immunologic responses, thinking about as we try to get closer to what the actual inciting event is for mycosis fungoides and cutaneous T-cell lymphoma. That also helps. Any number of our treatments can put patients in remission. I think that the best way to find out, in particular in terms of what is new or what is on the horizon, is always to you can look at the NIH website in terms of looking at what kind of trials we have across the country and around the world on CTCL. And I mean, our goal is, of course, not just remission, but an extended remission as long as we possibly can. But we have different subtypes of therapies, as well as others are looking at combinations of immunologics and trying even combinations of single agent therapies that we've done in the past to see about remissions, even if somebody's disease has progressed. So that's a number of different approaches.
Okay, thank you. We have a follow-up question to a previous answer you had given is, can you please explain inciting event a bit more?
So for some people or some types of cancer, there may be a risk factor, and or from a genetic point of view, some reason why within the genetic code that there's a change. Other things that people have looked into is and have not panned out are viruses. We also know that there's a close connection between skin-related cancers or Mycosis Fungoides and bacteria, particularly Staph aureus, and so a number of those things are why this happens in certain people and why it doesn't happen in many other people is the event or the events molecularly that we're trying to look at.
All right, thank you for expanding on that. How many positive biopsy results are required to confirm a diagnosis of MF? We always have biopsy questions. Dr. Wolner.
Yeah. The biopsy findings are very, we say, non-specific, meaning if you showed me this biopsy and told me it was, and especially in early stage disease, and told me it was eczema, I believe you. If you told me this was early stage mycosis fungoides, I would believe you. So it really depends upon a lot of different factors, what the clinical history is, what the clinical presentation is, or how things look. I'm guessing positive might refer to maybe something called the T cell gene rearrangement. So this is if looking for if there are clonal T cells in the biopsy specimen. That doesn't necessarily put the nail, not I won't say that, but it doesn't necessarily nail the diagnosis, because you can still see clonal T cells in benign things like eczema. So I would say having multiple biopsies showing features consistent with Mycosis fungoides as well as the clinical picture would all kind of support and favor it. We really rarely have things that just kind of say this is what it is, unfortunately, and it requires kind of a coordination with the whole team. If things are very advanced and later stage mycosis fungoides, it kind of usually becomes pretty clear. But I would say if there's a little bit of uncertainty about what's going on, that also maybe can be seen as a good thing. It could also still be an inflammatory thing and it's not clearly presenting itself.
Okay, thank you. Next is, how common is it for people with PCFCL to have systemic involvement? What percentage of patients have eventual other types of lymphoma?
I think it's a primary cutaneous follicle center lymphoma.
Usually if people present with cutaneous B-cell lymphomas in our workup, it's very rare for people to have systemic disease. In fact, it's probably around 10% or less. In terms of localized relapse, that can happen somewhere between 30 to 50% of patients, depending on the nodularity of the disease and then also sometimes how they are treated. Others will, and the patients will say that this is one that stress tends to bring this out. I think having said that, because it's also a low-grade lymphoma, you're also looking at whether it's going to transform to something higher grade. And so, but that's why we end up following people for, years and decades, because for low-grade lymphomas, even if they're cutaneous alone, they are notorious for having kind of late relapses as well as asymptomatic progression. So while it's low and the long-term outcomes are incredibly good, in the 90% range, it does happen, and you always have to make sure that there's no systemic involvement whenever somebody gets the diagnosis of that.
All right, thank you so much. Our next question is targeted radiation. So in your opinion, from what you have seen, is targeted radiation the best approach to a bump that was cut open, cleaned and stitched, and later learned to be PCMZL? There are no clear margins or they are unknown, and PET scan showed no cancer anywhere at all. Options are to do nothing or accept what seems to be low-grade, shallow targeted radiation where the spot was. So this is very patient specific. So I think I should maybe phrase it as, have you had any experiences like this?
Well, I'm smiling because I think Zach and I might have the opposite answer just by some of the patients we have together. But Zach, do you want to go first?
Well, I'm guessing it sounds like they were treating this, well, in general, it sounds like based on this, they're treating it as a cyst or something. And based on that, usually they don't submit this for margins. So the pathologist can't clearly assess if it is or isn't out, which as pathologists, assessing margins for lymphomas is very challenging. It's not like a normal other cancer. So that in itself is a separate issue. But I would say from the data we have, either surgical excision or radiation for this can result in a 50% cure rate, especially for whether it be primary cutaneous marginal zone lymphoma or primary cutaneous follicle center lymphoma. So if this was considered an adequate excision, you could leave it at that. If you're feeling extra cautious, you could consider radiation in this scenario. The other thing to consider is marginal zone lymphoma can be due to chronic antigenic stimulation. So I'll just talk with your provider and get a thorough review of systems just to see if there's anything else going on that could have triggered this. So this could be like an H. pylori infection, which causes GERD, or this be an autoimmune disease, something underlying this that causes to kind of rear its head. Just make sure that that's been assessed, because that's something that we can manage and even cause this to go away on its own in that round. Now you can take it away, Mary. Hopefully we didn't disagree. We'll see.
So I think that I agree with what you said. I think to underscore that how incredibly rare this is. And with that, almost all the data that we have is retrospective, which in and of itself has its own biases. I think that some of the retrospective data look at those that have had radiation that have some better outcomes and longer remission rates, along with having a complete excision. That's older data, and you could argue it either way, that cancer is a microscopic illness, and that can you get the cells that even if the margins are clear, that may be outside, or looking at it as if there's nothing that one can see, do we leave it alone and save radiation for a different time? And so I think that it all depends a little bit on where it is, about patients' comfort levels and the like. But I always send our patients to radiation oncology to at least have the conversation and have them look at the area in terms of if there's any sort of residual nodularity or the like, and then have a one-on-one conversation about what the risks and benefits are.
So it sounded like you agreed, so that's good. So we are a little bit over halfway through. So if people in the live audience, if you have any questions you want to enter, please make sure you put it in the Q&A, and we'll make sure we get those answered for you. So have you experienced patients with lymphoproliferative disorder in the mouth, and how to best diagnose whether LYP or PCALCL?
So trying to follow the question a little bit, because I think when any of us think of in the mouth, we think of kind of mucocutaneous, and Zach helped me out here, but in terms of lymphomatoid papulosis, if it's surrounding the mouth versus in the mouth itself, you're kind of talking about a little bit of a different entity than you would with lymphatomatoid papulosis or primary cutaneous ALCL.
I think that once you get in the oral mucosa, it's a little different world. So I just making sure that sounds like a biopsy was done and maybe found something that was CD30 positive, and that's why they're trying to, this is the differential. A lot of things can be CD30 positive, just making sure that they fully evaluated this, know this is in the mouth, look for other things that can happen in the oral mucosa. As for differentiating the two, usually just in general, it's based on clinical history and an exam. LYP is something that tends to come and go. So you kind of get them in crops and then they self-resolve, whereas primary cutaneous anaplastic large cell lymphoma wouldn't tend to do that. And it would look different as well. But as for the mouth, this is not something I've personally seen. Doesn't mean it can't happen, but this is something where I think there's maybe something that needs to be explored a little further with your clinical team.
All right,
And
thank
I
you.
think I think to add to that, that none of the, I think it's incredibly difficult, as all of you know, in terms of trying to put some of the manifestations clinically of what people have into the titles that we have. And we're still, you know, all the time evolving into other names for things and other ways as we learn more molecularly about how things behave, about how to characterize. But none of these lesions read the textbooks, or I guess no longer textbooks for some of us are older than others. But in terms of trying to figure out, I think many times people will look at something, and I know for myself, as Dr. Wolner said earlier, you're looking a lot at clinical behavior of the lesion. And sometimes while they may not fit any of the other characteristics, they may behave most like one of these entities that are being discussed. Which is why cutaneous lymphoma, as everyone knows, is an incredibly multidisciplinary treatment approach. And we're all having meetings all the time discussing the patients and coming at it from a number of different viewpoints.
Always learning.
Thank you. And next we have mycosis fungoides. What is a good way to resolve itching, especially at night?
So I think one thing to do is treat the primary, like do a treatment, like whether it be acitretin, phototherapy, any treatment for MF should help with itch. But then we also have therapies that just treat itch. So they wouldn't necessarily treat the mycosis fungoides, but help with the symptoms, so it's not making your life miserable. And there's a lot of options there. I think usually the first thing people try are things like Benadryl, which you've probably heard of, or a prescription version of that called hydroxyzine. If that doesn't work, there are other things we can try, like gabapentin, which some people may be on for kind of pain or neuropathic pain, whether it be like sciatica. But this can also help with itch, especially at night. There's other over-the-counter lotions like Sarna lotion one can try, which is kind of like the icy of icy hot and causes kind of a cooling sensation. You can put that in the fridge. There's lots of different tips and tricks and things to try, and prescriptions your doctor can give. But ultimately, I'm hoping that if you get on a good treatment plan, that will get the itch better too.
Thank you. Next we have, can you talk about lifespan? My husband has Sezary syndrome stage IV2B. Everything online says 2 to 4 years, but his doctor says decades. And I know this is a tough generalizing on lifespan, not this particular person.
So I think the way I would answer this is, again, never having met the person and not seeing the characteristics of their disease or the specifics of it, is that while it is true that the data that we have has a much talks about a much shorter life expectancy, a number of that data is quite dated, and was before a number of treatments that we have, as well as a number of other approaches. And so I think that from the point of view of, as we all know, that none of us are great at being able to predict any of this. The other thing I think to say of note is that there's all different versions kind of stage 4B, and thinking of and how that manifests itself and how it behaves is going to be an individual sort of thing. I think the other things that are not predictable is whether there is any, there's any transformation, and or, as always, one of our biggest concerns is, of course, infection. And so things like, and of course, Dr. Wolner can help me on this, but things like, a number of different approaches to keeping one's skin integrity the best it can be, and the like. I don't know, Zach, if you would like to comment on some of those.
Infection is definitely one of our biggest concerns with this, due to this disruption in the skin integrity and the role of staph plays in this. So things you can do to kind of decrease the amount of staphylococcal load is, like, we recommend this for kids with eczema, because this often has a similar staph kind of disease interplay, which is it's called bleach baths, which sounds horrible, but it's essentially creating a swimming pool in your tub. That's one option to decrease staphylococcal colonization. If you're not a bath person, you can do a kind of recreate one in like a little tub. Not tub, what am I trying to say? Bucket. And then just do like a sponge bath with this. And that's, again, just something to try to decrease the amount of staph. And then following through with your treatment is, once you get less disease activity, the skin will kind of begin to heal and have less kind of cracks and breaks, allowing for staph to enter. But I think the main important things, if you have fevers, chills, and so has any concern about a potential kind of infection, to let your doctor know immediately.
Great, thank you both so much. Next we have, how frequently does the cost of treatment or therapy become a major consideration in your choice of medicine, and how you share that with your patients?
So I think we can probably both answer this. But so I think some of it's going to be a little bit different when you're in an academic setting, in terms of we are a little bit farther removed from sort of how much things cost. After doing this for a couple of decades, I think one of the way that this comes into play for me with my patients is related to, frankly, our healthcare system and what makes sense in terms of what is the resource burden or resource toxicity for the patients themselves. We all have medications that we think work, some better than others, and also related to what different kinds of what we call comorbid illnesses or other things are going on in somebody's body. But from the point of view of, I think, at least for me, it's about what I think is going to be best served for the patient themselves at the time, and that whether there is, again, we've talked about transformation of disease, whether what do the rashes look like, and that kind of thing. There are a number of our medications and procedures that we use that are notoriously incredibly expensive. And how one approaches that is, again, is a very unique and one-on-one conversation with the patient, in terms of, thinking about, to me, it's thinking about toxicity from the drug and the drug profile first, but also letting people know if there are treatments that are more expensive or known to be harder to get, being aware of that as well. Zach, did you want to add anything to that?
I think that's exactly right. I'm assuming this is in terms of cost for the patient or the cost for the healthcare system in general. I think usually we try to put the patient first and then work through any cost barriers that exist. But sometimes there's hurdles that can't be cleared, whether it be from insurance and issues, which are unfortunate, but we work our best when there's also resources through the Lymphoma Foundation, the Cutaneous Lymphoma Foundation, that provide monetary support if needed. So that's another potential avenue to bridge gaps.
And some of the some pharmaceutical companies do have some programs that can help with that. And typically in your physician's office, there is someone that you can speak with on that can help you look and see and give you the contact information on that. So there are some opportunities out there for assistance. So thank you both. So we have about 10 more minutes left. So we still have a few questions to get through, but if you have any that you want to add into the Q&A, please do so now. Most recent literature describes lumps and bumps, where previously I just noted tumors as part of symptoms. What has changed?
I'm not certain. Usually, well, I wouldn't call these symptoms. I would call these like findings. And there's sometimes called patch stage, plaque stage, and tumor stage, are kind of vague terms that can be used to describe mycosis fungoides. I don't know if that's what's being referred to, but I'm not sure if I totally understand the question. I don't know if they could post clarification. Maybe we could help with that. I don't know, Mary Jo, do you?
I'm not sure from the point of view of from a research point of view. I haven't seen things being referred to as sort of as lumps and sort of as lumps and bumps. So I'm just trying to get a sense of, it's hard to we apologize. It's hard to discern what the question actually is asking.
And so the person asked the question, if you could put some clarification and we can attempt to answer what you're looking for. Our next question is, should MOGA and photopheresis be used simultaneously?
So this is an this is an investigational question. A number of people have been looking into this, and we are still coming up with what are the toxicities related to combining the two as opposed to doing them kind of in series. But a number of people have wondered about kind of, can you enhance T cell activation in terms of improvement in the disease, and or could you jumpstart some of the ECP by clearing some of the cells prior to or earlier on than ECP, since it usually takes about 6 months to work. But as always, whenever we do something, is looking at it scientifically to make sure there aren't some unintended consequences that we're just not aware of.
All right, thank you. With patients being treated with MOGA, how long have you seen consistent efficacy?
So if we're talking anecdotally, there are always a set of patients that respond that can respond for years. I can remember one person in particular whom had 10 or 11 lines of therapy that unfortunately was in the hospital every couple of weeks for an infection of one type or the other. And when MOGA first was made available, this was kind of the best thing that she could tolerate, and she ended up staying out of the hospital for and living another 2.5 years with the mogamulizumab. So a lot of people are also looking at, back to some of the earlier questions when we talked about kind of triggers or targets, about why some people's disease, I should say, excuse me, can be hypersensitive to mogamulizumab, and trying to sort out whose disease can be more sensitive. But we have seen incredibly long-term remissions.
Great. All right, next question we have, does treatment halt progression or just help symptoms? And that is a very broad question because there are many types of treatments. So I'm not sure how you want to tackle this one.
I would say our goal is to get remission as well as treat symptoms. Whether or not this will delay progression or stop that is not certain as far as I'm aware. I don't know if Mary Jo has additional insights, but our goal is to get things clearer and also feel better. I would say it also depends upon what your goals are as well. So again, in certain cases, getting things entirely better is not necessary if your goal is just to make sure this has less impact on your life.
And that just to underscore it, I think that is a very individual conversation in terms of there are some patients that want that only the best possible remission is is the answer. Others are content with occasional skin flares, but are able to do things in life that they weren't able to do for a number of years. And there is such a wide range with regard to what people are willing to have as their everyday new normal.
Okay, thank you. And this next question just kind of really ties into the last, is that they've been doing NBUVB for 3 years. Their MF has improved, but they have no signs of remission. So specifically on the NBUVB, have you seen any of your patients go into a form of remission while under this treatment?
I can take this one, and I'll be speaking in general. I have patients on this, and anecdotally, who got a lot, no evidence of this while they're on narrowband, but others who still have some disease but are improved, and they kind of are maintained on it. So I think, again, there's a wide spectrum here, and it depends upon, like we discussed earlier, what your goals are and what is working for you. And there's different ways you can go from this. So you can take a break, you can try adding on other things, switch course to get all together. So there's lots of potential options to take here. And again, it's something you'll have to discuss with your provider if this is working for you, and if not, what to do next. But not unheard of.
Okay, thank you. So this is our last question that we have, unless someone sneaks one into the Q&A before we finish. How effective is surgery to remove a lesion of PCALC? How deep should they go? Does it remove muscle or lymph nodes? Now, again, in your experience, what have you seen with your patients?
You want to take that one, Zach?
In the cases I've often gone to radiation, but there may be something in your scenario that they're not doing that. Like we kind of talked about earlier, I don't think they've defined surgical margins for this. So there's no clear guidance on what should be done. I think it would be enough to remove the clinical lesion. And if that means going to muscle in a certain case, they might have to, but usually in my experience and in general, that doesn't need to be like that. Usually we don't go to lymph nodes unless there's evidence that this is not a primary cutaneous anaplastic large cell lymphoma. If this is a systemic, we shouldn't be cutting this out. You shouldn't be doing a lymph node. So a primary cutaneous one should just be in that one area, and it should be responsive. I don't know if Mary Jo, if you have anything to add.
Yeah, I think what you're sort of saying in terms of if they're going towards a lymph node, that there may be something that they're concerned and trying to discern whether it has local extension, which then would make it not necessarily only primary cutaneous ALCL, and you would consider doing it differently. But sometimes just looking at the lymph node itself, my surgery colleagues tell me, is not enough to be able to say whether there's actual disease involvement or not. I think many of our colleagues, and I don't want to speak for the surgeons, right? There's not, as Dr. Wolner said, it's not particularly defined, and so many of them will approach it from different angles. I do think they try to try not to disrupt different planes in terms of muscle or the like, because of lymphoma being slightly different. But we have had people go into a number of people go into complete remissions with surgical resection alone.
All right, thank you both so much. And with that, that is our last question. So I want to say, Dr. Lechowicz, Dr. Wolner, thank you so much for taking the time out of your schedule to answer questions for our community. We really appreciate the time that you dedicate to us. And I want to thank everyone for joining us for today's webinar, and we hope that we will see you again at a future program. And please don't forget to take the survey that will pop up as you exit out of Zoom. And thank you again.